this plenary today. It's my pleasure to introduce Thea James, who is the Vice President of Mission, the Associate Chief Medical Officer, and Co-Executive Director of the Health Equity Accelerator. She's an Associate Professor of Emergency Medicine and Director of the Violence Intervention Advocacy Program at Boston University. Dr. James recognized, even as a medical student, that although we all say we embrace the statement that we use at Mayo, for example, that the needs of the patient come first, that often our orientation during training, which is mostly, if not exclusively, associated with biology, sometimes misses that mark. The sense increased during her training as an emergency department physician, so she was ideally posed to become involved in a different way of interacting with patients. As Vice President of Mission at Boston University Medical Center, she works with caregivers in promulgating a novel model of healthcare delivery, which I heard about several years ago at a meeting of the Association of University Cardiologists. Her role is to coordinate and maximize the institution's relationships with strategic alliances with a wide range of local, state, and national multi-sector organizations, including community agencies, housing advocates, and others that partner with Boston University. Their goal is to foster innovative and effective new models of care that are essential for patients and communities to thrive and reach their full potential. This includes a focus on intersections of health and wealth, economic mobility, and upstream drivers of predicted poor health outcomes. These models are critical to operationalize equity in the broadest sense. I think you'll find her approach enlightening. At the end, we'll hold the questions till the end, at which point in time, hopefully you will put any questions you have in the app. There are microphones for those of you who wish to use them, but I've been asked to make sure that people do not give lectures from the microphone, and I'll take that responsibility seriously. So for today's plenary presentation entitled Choosing Equity in Healthcare and Organizational Transformation, please welcome Dr. Thea James.
Good morning, everyone. I'd like to say thank you for the invitation to be here today. It is quite an honor to be able to share this time with you this morning. And I want to say, I just want to start out by saying, I'm going to talk today a little bit about and really share with you about an organization's transformation, a commitment to, I would say, an enterprise-wide transformation, not a project, but a full-on pivot, not checking a box just to address the topic of the day, but a full-on pivot in perpetuity. And to achieve this type of transformation requires insights and understanding intersectionalities of the problems that you're trying to solve. For example, if you are trying to address or change the no-show rate in a particular clinic, you know, why a certain number of patients don't show up or a certain percentage of patients don't show up and it's a higher rate than one would expect. Generally, an organization would go into a room and try to figure out how to address that, how to change that. And it's usually something operational, you know, from the ops people that they will be the people to solve it. But really, you cannot address a problem like that. You certainly can't correct it or improve it without understanding and interfacing with and engaging with the subjects of the no-show rate, like the patients. And so I think that in medicine, you know, we've really not been taught that in medical school, and quite frankly, it's still rare. you know, to do that in medical school. So I'll tell you a little bit more about the hospital, and then it'll hopefully make sense to you. And if it doesn't, we're going to have a Q&A, so you can feel free to ask me afterward. So anybody recognize those machines? Anybody in here, I should say, old enough to recognize those machines? You know, I thought it was really, really interesting, but for me to be here today with all of you at this particular conference, because I used to be a medical technologist way back in the day, and I used to operate this machine right here. And the last time I saw it was when I Googled it before I came here, and I was like, wow, I can't believe I used to do that for a living, and I worked a night shift. And there used to be like this, the serum would be going through these little tubes, and you'd have to like look at the bubble patterns, and they all had to be equal. You know, you just like go all day long, your whole shift just watching this thing and making sure this thing, you know, did well. And that job ended because it was a night shift, and one morning going home, I guess I fell asleep, and I hit a tree. I crossed Buford Highway in Atlanta, hit a tree on the front lawn of the Centers for Disease Control. So that was the end of my days running that machine. But I thought it was interesting. So I want to tell you a little bit what I'm going to talk about. I just sort of gave you an overview of what I wanted to share with you this morning. But basically, it's going to be in these three sections right here. I'm going to tell you about what led us to transform. I'm going to give you an example of what that transformation looked like. And then I'm going to share with you the power of the subjects, you know, the community, the patients. And so a little bit about our hospital. It's what's called a safety net hospital. In America, they're called America's Essential Hospital. So you can understand what you might see in a hospital like that. For example, more than 80% of our patients are government insured. We also have a health plan, but we're a pretty large organization, I should emphasize, because if you look at the Massachusetts Medicaid, you know, we call it Mass Health. And we are an accountable care organization, which means that our organization is accountable for how well our patients do. And we are 40% of the covered lives under Massachusetts Medicaid. So it's a pretty, you know, pretty tall order that we have. 1 in 7 black babies in Massachusetts are born at our hospital. 1 in 12 Hispanic babies are born in our hospital, and 1 in 100 white babies are born in our hospital. We also have a health plan. And we are also the primary teaching hospital for Boston University School of Medicine. So you can sort of get a sense of what our population is like. You can imagine that they come from disinvested communities. And, but nobody generally ever questions that. There's a certain dominant narrative and mindset that happens when you think about yourself as delivering any kind of service anywhere, doesn't have to be healthcare, for populations like that. And it's almost like what you are seeing is the natural order of things. That what you're seeing, if people come from those neighborhoods, it's inevitable that they will have lower education, that they will have lower income, and even their health status will be lower than other people, and their children's health will be lower as well. And so, but nobody questions that. Once again, it's like the natural order of things. But before I go forward, I just want to say, in my mind, it's economics, and it's all economics, because people can't prioritize health when they're prioritizing survival and these other things as well. And so there's one particular time in American history that I think we can identify as, in part, where a lot of this began. And I think it is back in the 1930s, right after the Great Depression of 1929. And you know, we had an economic disaster going on in our country. And FDR, President Roosevelt, was trying to resuscitate us from that economic disaster. And he had a brilliant idea. I mean, he was trying to create opportunities for people to build wealth. And as you know, one of the most common ways of building wealth in our country is home ownership. And so he created access for people to own homes. And he even subsidized developers, housing developers, to build more homes for people, but only if they agreed not to sell them to people of color, to Black people. And so right at that point, and that was called redlining, these were federal policies in place that not only prevented people from having access to the wealth building pathway, but the neighborhoods they lived in were sort of deemed as risk. So people could not actually get financial services like mortgages and things. So that was called redlining. But even if you look at COVID, you know, the COVID maps all over the country match the redlining maps all over the country. You know, it's so predictable in those neighborhoods what's going to happen and to the people and what their lives are going to be like. But again, no one ever questions that. If you suggest trying to address that or change that, people say you can't boil the ocean. And, you know, to that I say you're absolutely right, because where you set the bar becomes a self-fulfilling prophecy. If you think you can't do it, you definitely will not do it. And so that's kind of like where this whole insight for us started. And back in 2020 and 2021, when all things were happening in the country at that time, we were having these reckonings and things, we decided that we were not going to come forward with an equity commitment. And it was interesting how quickly, you know, so many of us, you know, well, many people came forward with equity commitments, because it seemed to me very quickly people understood equity, but inequity is in, you know, it's in everybody's full view for decades, but again, it's not recognized as an inequity because it's deemed to be the status quo, the natural order of things. So that's kind of like where we started. So in our hospital, for years and years and years, decades really, we've recognized that our patients had gaps, and we've created lots of programs, many of them disseminated across the country even. But these programs were designed to address the gaps people had. Like Children's Health Watch was started by pediatricians in our hospital, and they do lots and lots of research. They're a very strong body. And then we even had like a Grow Clinic. We still have it. It's for kids who are not thriving, you know, who are underweight. And then MLP is the Medical Legal Partnership. We have to call it Boston because it's been disseminated across the country, so it's in different cities. And that's helping people who I described from disinvested communities, help them with some of the legal issues that they have. The VIAP program is a program that we were one of the founding members of. It's a hospital-based violence intervention program for young people who come in with gunshot wounds and stabbing wounds and things like that. And you know, I will say that most people feel like these young people, that you can't help them, but their tattoos long ago taught me what was going on with them. You know, tattoos would say, living is hard, dying is easy. Death is nothing, but to live defeated is to die every day. Born to be hated, dying to be loved. And so that program actually enables them to alter their life course trajectory just by asking them what they want, what are their dreams, and helping them to accomplish that. Where they go and become people in, you know, the trades, they go to college, you know, they get an MBA, they become entrepreneurs, all kinds of things that they thought would not be possible. And then Street Cred is our approach to, one of our approaches to economic mobility, where we do taxes for people in the pediatrics clinics so that they can take advantage of earned income tax credit. And so there's lots of things we've been doing for a long time. But these numbers never change. These numbers never change. And we recognized that back in 2021 and 2020. So what we decided to do, instead of making a commitment to equity, was to look inside our own house. We looked at lots and lots and lots of data. We looked at policies, procedures, clinical outcomes, research, education, even human resources. We looked at our health plan. We looked at everything. And we looked at everything with the intentionality to find inequities in the form of disparity gaps. Now, lots of people study disparities, but it's rarely with the intentionality to close the gap. It's just identifying that it exists. But, and it's actually kind of traumatizing for the subjects of the disparity data to continue to hear this bad news, about themselves. And so when we looked across our entire enterprise, absolutely, we found things. And some people were pretty surprised at what they saw. Again, the inequities were there all along, but it seems like the natural order of things to people. So I'm going to tell you what we did from that point. It came from the COO and the CEO in our hospital, and it has to come from the top if you're going to do anything like this. I mean, some people tell me they have DE&I jobs in corporations, but the people won't let them do the job. They won't show them the data. All these various different things that make it impossible for a transformation or an improvement to occur. You really have to be willing to be transparent and vulnerable to be able to do this work. And it was so much better for us and easier for us to have an organizational culture that was willing to do that and actually drove this work to begin with. So we were divided into 6 work groups with 80 leaders from across the organization. And again, we looked at all these various different data points and things and analysis. And we were divided into those groups over there and on the right-hand side. And we were all charged with coming up with 4 to 5 various different gaps that we would work on with intentionality to close over the next 12 to 24 months. And there was an enormous amount of accountability involved in that. We met over and over and over again. We met monthly. We had to report out to the CEO and the COO, and we were on these big Zooms, and people really had to report out on where they were moving in these areas. And by the way, the things that people chose that they were going to work on, the approach to doing that could not look like anything we'd ever done before. It couldn't be just another identifying a gap or a disparity. It had to have an intentionality to actually close that gap. And so this is what the 6 work groups looked like, and these are some of the things that were involved in that. And I want you to take note of the dollar signs in there, because economic mobility we recognize is key. We recognize that is key because people are not going to show up for chemotherapy appointments when they have limited resources and they have to determine whether or not they're going to use those resources to feed their families, secure housing, and healthcare is definitely not going to be a top priority. And this is a reality. These things do happen. So all the while, when we're trying to figure out why people don't come, and in medical school, they would teach you, it's the patient's fault, that they're not responsible or whatever. Those things, first of all, never made sense to me. It's against human nature to me that people, given any opportunity, would choose suffering. So that never made sense. But we're focusing on economic mobility as well. And so these are the same work groups, again, in a much more granular form, none of which will probably make sense to you, but I just, wanted to put them out there as well. And so while we were doing this work, the OBGYN department had started to do some quality improvement work looking at the rate of postpartum hemorrhage in their patients, in pregnant women. And they had determined that the way they were going to do this work is they were going to interrogate the data back to the root cause. They were going to look at what they saw and interrogate it back to the root cause. And so I'll tell you a little bit more about that in a minute, but I'm using that to sort of explain how we got to form the Health Equity Accelerator. Because while we were doing this work, we sort of went into a room together, probably 15 of us, and for 2 days we had a consultant helping us to determine what it is we were actually, what was going to be the hub, sort of like a hub and spoke. What was going to be the hub of the work? What was going to enable the work, drive the work, be a consultant for the work? What body, would do that? And so we came up with the Health Equity Accelerator. The name Accelerator, we came up with that because of the OBGYN department's work, which I'll explain in a minute. And we decided is to transform healthcare to deliver health justice and well-being. And so this is what we came up with. All those areas where the arrows are on the right are included. And the areas at the bottom, those are the clinical areas where we found the highest rates of inequity. And so this is the leadership of the Health Equity Accelerator, and on the right side is the Equity Oversight Group. We still report out to that group every month. We just reported out to them last week. And in the beginning, we had those clinical areas at the top, but we also have enablers, that are going to be involved in each and every one of those clinical areas, like, the data. And as I was telling you, we had collected so much data, and we still do, have DEI training involved in it. All these areas, health-related social needs screening, which we've been doing since 2017, by the way, education and advocacy, and all of those areas are active. They are all active. And in many ways, they were already active. They just hadn't been operationalized with this level or this type of intentionality. That's the other thing it requires, other than commitment, is intentionality. We also had, I'm sorry, this is blurred, but when we first started doing this work, we were a little cagey about it. And so we just sort of didn't, share everything, but these dashboards were alive and still are alive. In fact, when we reported to the Equity Oversight Group last week, and this work that I'm telling you about right now happened over the course of a year. The CEO was the COO when we started. He's now the CEO. And he was like, well, all these things are green now, then, we're not, so we got to challenge, we got to move to the next level. There needs to be red. There needs to be red, or we're not reaching where we could be. And so now we've built this whole team out over a year. We have all these people in all these various different areas. We started out with COVID, but COVID was actually sort of like pre-accelerator. And then maternal health, and then cancer, diabetes, and now cancer. And so look at these enablers now. And I will tell you, the numbers in these boxes are a little lower than they are presently. For example, one of the things we did was we had this is around economic mobility. We had a JP Morgan Chase grant for $5 million to work on things like acquisition in communities to transform communities and economic mobility. So we identified 7 zip codes where patients live, who we serve, and we created pipelines for people to come into living wage jobs in our hospital. We started out with a goal of 52 people in a year. We had that 700 right there in about, I would say, 15, 16 months. And we're far beyond that at this point. And people don't just come in with entry-level jobs and things and stay there. We also have, in our HR department, we have a pathways program where people can go through really intense training, professional development for 6 months, and then apply for higher level jobs. Like one person I know was in environmental services, and then she's now like the manager in the breast center. So things like that. We have the same thing for the director level as well. And we're also just starting off where we have this screener. We screen all of our patients for things they want, like education, employment, food, housing, those type things. Now we are taking people who choose to, who want employment, and sending them for training as well. So working it's an ecosystem of work. We're continuing with the data. And when we look at the quantitative data, that is actually powered by and infused with or accompanied by qualitative data, which is the most important piece because it gives context to the qualitative data. I mean, the quantitative data. And we have built up an entire research department to support people in the hospital who want to do equity research, you know, helping them with professional development and grants and all kinds of things. We actually have equity fellows now. We also give out internal grants. And it actually took a minute, probably 3 rounds of grants for people to understand what the intentionality of the grants what the intentionality was. So for example, some people would submit proposals that were still identifying gaps and they wouldn't get funded. And then finally, you know, they got it. We started having office hours also to sort of help them. So this is what really defined the approach that we would use for every single gap that we identified in the hospital. So we saw that postpartum hemorrhage and other, you know, serious maternal morbidity issues were happening at a higher rate in Black women than white women. And so when the data was interrogated, the first thing, well, I think everyone in this room probably knows that what preeclampsia is. First thing we saw, or that they saw, was that it was mostly associated with preeclampsia or hypertension in pregnancy. And you know, the cure or treatment for preeclampsia is to deliver the baby, particularly in, you know, later stage pregnancy when it happens. And when they interrogated the data more, they saw that the faster that decision was made, the less likely these outcomes were to happen. And they interrogated it more and saw that the doctors were taking twice as long to make that decision in Black women. And so the thing that they did immediately, like immediately, was to standardize the decision-making process. They changed the protocol just to remove the variability. And at the exact same time, they were interviewing the doctors, the nurses, the midwives, the patients, to try to add context to the variability, to understand why that was happening. And just from standardizing the timing, the decision-making process, the gap closed. Pretty fast, just from doing that. And that's where the name Accelerator comes into the Health Equity Accelerator, because we want to do everything that we can do now, do it now, and do it fast. Like not take 2 and 3 years for things to happen. So the decision to incision gap closed just from doing that. And we did some other things based upon what the patients said when we were talking to them. Now, you know, that snapshot over there is just an example of how the data was analyzed and how that led to where to make the various different interventions. For example, if you look at like bias, for example, you can see how many things happen because of that or grow out of that. And what I was so grateful for, but not surprised about, because of our organizational culture, you know, the doctors were very forthcoming and very, very, you know, transparent about what kinds of things were on their minds when they were making decisions in people's, you know, about people's treatment. Sometimes, and it's on both sides in terms of like trust and that type of thing from patients as well. So here's some of the interventions we use. First of all, now our patients, our pregnant patients have blood pressure monitors, because sometimes they can't come to the hospital every time they're not feeling well, you know, childcare issues, various different types of issues. So they're now monitored 24/7 by someone who can connect to them. And we've actually had a couple of instances where someone who wound up having a stillbirth because of preeclampsia at a previous pregnancy had a normal pregnancy the next time because they had this blood pressure monitor. We also have birth sisters, or doulas, people call them. We've actually had them since 1999, and in another slide, I'll show you the impact of having doulas, the difference in outcomes when you have one. The patients also said they wish they had a chat bot. You know, they wish that they could have communicated back and forth with someone, you know, during their pregnancy. And so we co-created a chatbot with them. They talked about the questions they wish they had. And they also wanted educational videos. We also co-created that with them. I wish you could see those videos. I mean, they're very, very straightforward and very, very clear. And you can tell that the patients' voices are in those videos. And also, in the OBGYN department, they are working on creating a climate of anti-racism in their department. And so I don't know how well you can see this, but you can see what happens when you have a doula and when you don't. The advantage of having, you know, someone who understands you, someone who's relatable to you, that you can have, you know, walk you through your entire pregnancy. Definitely makes a difference. It also decreases cost of care because you have fewer NICU admissions, you know, neonatal ICU admissions, for example. So it makes a difference on so many levels. The patients have better outcomes, and it's at a lower cost. So that's what all of that intervention is leading to right now, 1 year later, in terms of readmission rates. And, you know, the N is not enormous, but we're definitely trending in the right direction. And so our CEO, who recently left to become the Secretary of Health and Human Services for the state of Massachusetts, which everybody in Massachusetts was so grateful and happy to see, because this is how she thinks. Now, she wrote an article just before she left. It was published, I think, 3 months before she left. And she was talking about this journey we've been on and the lessons that she has learned on the journey. One of them is that wealth is health. It's just what I was just saying earlier. People can't prioritize health when they're prioritizing survival. No one in this room, you know, I mean, in my mind, they're making rational decisions. I don't think any of us would, you know, make decisions in a different way. Time is a luxury. You know, I always think that medicine is built for doctors and other medical people, not for necessarily for patients. Agency is essential. We don't have to think that we know what people need. They know what they need. We don't know. And we, to have the best outcomes that we can have, and our goal in our hospital is to alter life course trajectory through, you know, addressing all of these things. You know, we have to trust patients, trust that they know, you know, what they're doing and that they have a reason for it. And timing is everything. One of the things we found out, particularly as we're going deeper now into the diabetes work and cancer work, that the diagnoses are made later than they should be. And it's happening by race, you know, at higher rates for people of color. And that averages are blind. And I guess a good example is, you know, prostate cancer is something that's pretty treatable these days. But for Black men, it still ranks really high. And so we shouldn't accept averages around diseases for people. They definitely should be tailored to specific populations that we're treating. And so the next piece is community engagement. And the way we dealt with this during COVID was really interesting because when we looked at, when the vaccines first came out, and you can imagine, you guys already know who did worse during COVID, right? The populations we served. And, but when the vaccination sites came out, that's not where they were deployed. That's not where they were set up. And so when people talk about, they can't believe people don't trust the healthcare system, well, it's that kind of thing. that happens your entire life, you know. But again, it seems like the natural order of things. They're just not prioritized. People just don't think about it or see that it's an inequity, even though it's sort of like Public Health 101, you know. But at any rate, so we started trying to figure out how the patients we serve feel about the vaccine. And we saw that they were less inclined to want to take the vaccine. And we looked internally among our employees, exact same thing. So we decided that we had to target that population. So we started hosting lots of Zooms. But first, our Vice President of Community Engagement and External Affairs, her name's Trina Cherry, she got a lot of leaders together, you know, faith-based leaders, organizational leaders, social leaders, all kinds of leaders across Boston, and got them on Zooms, and also to ask them two things, like, number one, we want to address the questions people have about the vaccines, but we also want your help to help us figure out how to create more sites. Where should they be? What should they look like? What should they feel like? How should they be operational? And through those Zooms, we were able to do both things. In fact, our strategy team and our operations team, they were like outside in the community, walking around with Trina and other leaders in Boston, going through various different buildings, looking at where potential sites could set up. I mean, you just don't see that happening, you know, from our ops teams and things like that in hospitals, like walking out with community people. And we were able to set up 6 sites, and we were also able to, the state was a great partner for us because they provided us with a lot of vaccine, but we were able to vaccinate that population at 4.5 times the state was able to do. And so, again, it's just intentionality, and you know, you do what you intend to do. And so, out of that has grown lots of different partnerships across Boston with our hospital. Really, really deep partnerships. And nowadays, we're all over the place. You know, we're in the community talking about diabetes, talking about the White Dress Project, which is specific to fibroids in women. In fact, July is Fibroid Awareness Month. All various different types of community conversations are happening. We are also, and these are the kind of things that she tries to do, but one of the things I want to highlight is in terms of like, we have something called an Equity Partnership Network, which is multiple different community groups that inform us about things. For example, when we were choosing those 5 clinical areas where the inequities were highest, they helped us choose in which order they would come. After we did COVID and after we did maternal health, they decided, should it be diabetes, you know, should it be cancer, should it be hypertension? And so they inform us on pretty much everything. We are down on Martha's Vineyard now for and I think this is the 3rd year in a row, during August, doing various different types of talks on like mental health, economic mobility, maternal health, all kinds of things. We have these panels and things down there. We'll be down there next month between August 7th and August 17th doing that. Every place. We're actually also having a summit, our first summit, our first Health Equity Accelerator Summit in September. So they're all over the place, that department, that community engagement, and there are not that many of them, believe me. But they're just out there working all the time. And this is just more of, you know, what I was talking about. Trina's team is out there at all the various different events in the community, like Haitian Flag Day, those kinds of things. We also do things like, we have a rooftop garden. We have been named one of the greenest hospitals in the country. And one of the things our facilities SVP is doing is finding ways to share our solar energy panels and things with the community to either mitigate or, decrease their costs, even down to 0. And so, you know, he's doing a lot of work with that right now as well. We work with all these various different companies as well on various types of things, including, you know, thought leadership and things like that. She and I are both on the Governor's Advisory Council on Black Empowerment, and That's a real council. I mean, we are face to face with the governor. We have met all of the secretariats, and you know, the governor really wants to move on these things as well. And when we're in that room with her, I mean, she is really biased towards action. And every time we're in there, you know, she wants to know, what are we doing now? And what are we doing now? And what are we doing now? It reminds me of the transformation we were going through. We have a CRIM lab, which is the Center for Regenerative Medicine. So they work on stem cell types of things, particularly for sickle cell. At the bottom there is Trina in the middle, but you have the two, the McCourty twins, football players who have always led that work for us. And we also invest in, we belong to something called the Healthcare Anchor Network that focuses on building more inclusive, sustainable local economies through hospitals being intentional about how they hire, invest, and procure, with, again, an eye towards, you know, inclusiveness and focusing on economic mobility once again. So we have sort of like an ecosystem of this work. You know, we do what we do internally, we do what we do externally at the exact same time. So this is the last thing I'm going to say. In Massachusetts, when you build onto your facility, the state requires you to give 5% of the total construction cost to the community. And in 2017, we had done a campus redesign, and the state has to approve whatever you propose. We asked the state if we could commit. We only had $6.5 million. Again, we're a safety net hospital. Other hospitals at the exact same time, like Children's Hospital, had $53.4 million that they had to spend. The Mass General Brigham right now has one of $69 million. You know, luckily we work together. We sit at tables and stuff together. But long story short, we asked if we could invest ours in housing and that type of thing. We were approved to do that. One of the things we invested in was a Healthy Neighborhood Equity Fund that will only fund developer proposals that provide access to affordable housing, green walking space, transit, healthy, affordable food. And so we invested in 223 units of mixed income housing, some to rent, but also some to own. So opportunities for generational wealth building. On the bottom level was a retail fund that we also invested in for retail businesses. So there was a grocery store there. The owner lived in DC. They built the store out, but this is the approach that's intentional, by the way. You know, banks are not really anxious to fund businesses in those neighborhoods, unless, if they do, it's associated with high interest rates and terms that require you to pay back really quickly. And those are two things that will open and close doors really, really fast in the community. And so we gave them, a no interest loan for that store. And we also gave them some operating capital, and we gave them terms that, you know, that are reasonable, like 15, 20 years to pay the money back. And then the owners, COVID happened, the owners built out the store, but they didn't open it because of COVID. In the meantime, he said, we'll find you 2 local operators. Well, when we found these 2 local operators, there were these 2 guys, these black guys, who already have businesses. You know, they're not new in this sector. And they had no interest in being operators. They wanted to both own the store and the physical space. Because, you know, it's a business, you know, it's a generational wealth building opportunity. And so it took us 16 months to get the other investors in the capital stack to actually agree to change the structure of the loan, but they finally caved and we were able to do it. And so it is now called Nubian Markets. And, you know, it's a halal market. And so, you know, it also has a community space. That whole space was informed by the community, like what they wanted that space to represent for them, what they wanted it to feel like and be like, and the types of foods that would be in there. I can't even begin to come close to help you understand or express to you how great that food is. That food is outstanding. It's excellent. Actually, one of the chefs was featured in Bon Appetit last year. He's also been chef in residence on Martha's Vineyard in the summers, and so it's incredible. It's absolutely incredible. So there's a cafe, there's a halal butchery, and then there's a grocery store. So all those things in once, as well as the community center. So we are helping them a lot, you know, partnering with them on all kinds of things that are being hosted there. We also invested in something called City Fresh Foods, which is a long-standing business, 20-some-odd-year-old business that feeds seniors and people like that. Their rent had increased 150%, so they wanted to own a building. And once again, we were trying to buffer the sort of extractive capital that they would have to engage in to get this done. Again, we gave them like a no-interest, actually, I think we gave them like a grant, like $500,000 grant. We talked to Children's Hospital, they also gave a grant. We talked to the city of Boston, they also gave a grant, but for $1 million. And they subsequently gave them a $17 million contract for Boston Public Schools. We've invested in community land trusts, which basically are when communities own the land, and it basically helps to control the cost of housing. So again, it's an ecosystem, you know, that we do. And this is absolutely the last slide. In terms of procurement, we built this behavioral health center in Brockton, which is about, I don't know, 10 miles or so south of us. And we had a developer of color build this whole thing. It's net zero carbon emissions. We employed people from that surrounding community to work there. So again, focusing on economic mobility inside that place. By the way, the other thing we support is businesses that provide equity stock ownership for their employees. And so again, it's intentionality, it's like commitment, willingness to be vulnerable, willingness to you know, be transparent, and it's been fun to work there. I mean, I've been there a long time. I won't say how many years, but you saw if I worked on a smack machine, you know that I'm not 30 years old. That's for sure, and I certainly don't look 30 years old. So, but at any rate, you know, it's been fun to work in an organization that has, you know, that kind of culture. It's hard work from the perspective of you're always on. You know, we work like we really work. We work pretty hard, but you know, we get to, you know, see the fruits of the labor all the time. So. These are just, you know, just some points around the community and how much they can help you with whatever it is you're trying to do. It's just easier. It's just easier. Start with the subjects of whatever it is you're trying to figure out. Just start with them, and you're likely to be good to go. I saw a board yesterday about why people who are attending this conference, why they do what they do, what they like about their work. And I would say the common theme was that people want to help patients, you know, they want to, you know, provide great results for people and that type of thing. And so, I mean, I think this is an opportunity to look how you can do that, how you can do it even better, what's missing, you know, what has somebody told you can't do that is not possible to do? Like, you know, think about that. So anyway, I hope I've shared something that makes some kind of sense to you guys this morning, and hopefully is helpful to you as well. And I'm open to any questions. Thank you so much. Thank you.
Thank you so much, Dr. James. Terribly insightful, but I'm sure there are a large number of questions, and the audience wishes to use the microphones they can, but some have come in through the app. And I guess the first and hardest and easiest question is, how do you finance all of this? And how have you been able to build the ability to do this? It's clear Boston University is not the richest medical center in the state.
Not at all. It's a good question. You know, we tend to build things, and we don't wait till we have the money to do it. We build, and then the money kind of like comes. I mean, there is some intentionality around that in terms of, you know, talking to potential funders about the work we're doing. Also, you know, when we get a grant, something like the JP Morgan Chase grant for us, you know, the ink is never dry. You know, it starts out as one thing, but We sort of evolve and morph as different opportunities present and different things change in the situation that we see that we didn't see previously. But you have to be attached to funders who aren't rigid, you know, that allow you to provide opportunities. I'm using that as an example because the work we started out doing with them sort of changed a bit. And then there was a funder who saw that and decided that they wanted to contribute, you know, to that as well. So the answer is we don't look for the money first and then build something. We just start building and the money comes. I mean, we get grants. Some people, once they saw the accelerator, some people donated money on behalf of the people who actually created that. You know, the people who actually led that work, you know, like the CEO, for example. And, you know, people wanted to fund and the sustainability and the perpetual growth of and transformation of that work.
But some of the money is in the investment into the various activities, and some of it has to be for the time that you and your colleagues take away from clinical or research activities within Boston Medical Center themselves. How does that work?
So it depends. I don't do the research end of it. That money comes from, some of it's internal, you know, because a lot of the stuff that we do does not come from our balance sheet, especially that work in the community. A lot of that is the determination of need money I was talking about that we invested in the grocery store and that type thing with. Some of it comes from Boston University. You know, some of that comes from our Boston University medical group, which is where all of the people who have academic appointments work. I mean, it comes from, it's a variety of spaces. Now, I don't get any, any reduction in my time clinically. First of all, my clinical work is volunteer work. I don't get reimbursed for working in the ER. I do it because I love it, and it informs the other work. Everything I know, I learned from the patients, from asking them so many years, like, what would it take for this not to happen again? And that's where I would start my clinical intervention, because I know, you know, if it doesn't align with what their priorities are, it's not going to work. And so I don't get, you know, any time in any of these financial arrangements. None of that doesn't go to me for anything. I'm 100% paid by the hospital itself. So.
But you're in an environment which is sympathetic to these sorts of efforts. It sounds like through the state, likely through the city.
Right.
How do you begin to think about extrapolating these types of programs to areas that are a little less amenable and much more cynical?
Yeah. So first of all, I also want to say, you know, Massachusetts is a pretty progressive state, and if you think about the Massachusetts Medicaid and accountable care, we have these like waivers, these sort of like 11, 15 waivers that is sort of like gives you an opportunity to, so when Massachusetts reimbursement switched from fee-for-service to accountable care, they essentially were saying, you know, we're no longer going to reimburse you for patients who come in the hospital over and over and over again with the exact same thing. We're not going to do that. We want you to focus on determinants of health, and we want you to focus on decreasing costs and improving outcomes, and achieve that by focusing on determinants of health. So there's quite a bit of money associated with you know, getting that done, and the present waiver has sort of evolved. It seems to me it's evolved as we've evolved, both as a state, as a healthcare system, and probably to some extent to a country, because there's more finances for us associated with addressing health-related social needs, for example, for decreasing diabetes out of control. you know, for addressing cancer, hypertension, maternal health. I mean, there's lots of money associated with achieving those things. And so we are compelled, you know, for lack of a better word, you know, it's in our best interest to actually do those things. So a lot of money comes from that, by the way.
One might think that the ability to talk about and provide data about how well you're doing might well be important for extrapolation of this model outside of Boston and Massachusetts.
Yes.
How's that going?
You know, haven't gotten like a lot of feedback on how's it going for people, but a lot of people want to hear about it. A lot of people want to learn about it. The Joint Commission was just at our hospital last week. They're going around now, and I think they have, I can't remember all of them, but there's 6 categories that you are evaluated on. And they told us we did very well. Some things, they said we're doing some things they haven't seen anywhere else, you know. For example, the blood pressure monitoring, that's in more places now, but they say we're the only place they've seen it start at 20 weeks of pregnancy. Because what we've been able to do is identify chronic hypertension that people had that wasn't necessarily known or identified previously, because you start later when preeclampsia generally starts, but we're starting like much earlier. So they actually had us on their website even some months ago as a model, you know, for this. So we go around different places in the country talking to a lot of people who want to, you know, hear more about it and learn about how we're doing it.
It's one of the reasons you're here, by the way, obviously, but it would be important to facilitate the appreciation of the improved outcomes, because if indeed there's return on investment, which
Yes.
is what you're suggesting there is, then that becomes very important for other places that might be more resistant to these sorts of approaches.
Right, but you know, I mean, I think there are a couple things, you know, that I feel is worth, you know, worth mentioning. I mean, I don't know what the resistance comes from for people, because if you allow it to be driven by the people you're trying to address and help, then it's really so much easier. So much easier. You know, it's just so much easier. It takes so much less time. There is, without question, a return on the investment, because you have to like move it to thinking about, particularly, let's just say, the economic mobility piece. I mean, just hiring, you know, more people, enabling people to change their socioeconomic lanes. It's sort of like to me, it's about creating and capturing value. You create or propose a value proposition to a person that enables them to alter their life course trajectory, enables them to be financially stable, secure, and that position they now have, they can now contribute to your economy versus relying on the economy to take care of them. You no longer have to carve out those subsidies and things from your budget. It impacts the GDP and everything. I mean, if someone in our family or adult kid or a friend's adult kid sort of has an event where they lost their job or whatever, the intervention is going to put them on a pathway for them to become, to have self-determination and sustainability, security going forward. But when people from one of those communities comes with the exact same problem, we tend to send them to subsidies of some sort, like food stamps or some other thing. And that dominant narrative I was talking about earlier, it's like, what makes us make those two sort of like different decisions for different people? Because then we're perpetuating that problem. We're perpetuating the budget being higher and continuing to get higher. We're perpetuating like poor health outcomes. We're perpetuating the very thing that we're trying to solve for. But when you don't understand the root causes of it, you just continue, to drive it. Honestly, it really is not that hard. What's hard is changing the narrative in your mind that makes you continue to do the same things over and over again.
Several questions that came in. Does the involvement of the community and the fact that you have so much interface with the community mitigate the issues of security, crime, etc., which are problematic in cities nowadays?
Yeah.
And how do you and your initiatives interdigitate with that?
So, again, we have lots of partners in this space. You remind me right now of my COO. He's the one who's talking about we need more red in here now because we need to push ourselves. He is always talking about impact. What is the impact, that we are like having in the community? And so I would say that we are on that path of evaluating that type of thing, but we're early in this organized approach to this work. Like I said, we've been doing certain things for a while, but we are having an intentionality now to have measurable impact. And that requires partnerships that we have like tons of. The city government, state government, various different like housing developers, all kinds of community development, financial institutions, CDFIs, community development organizations, all kinds of groups that we partner with in this work. In fact, we are about to do a full-on sort of development and creation of an approach to economic mobility. One of the things we're looking at is the cliff effect. I was sitting this close to the governor week before last, talking to her about this cliff effect, which is when you live in subsidized housing, for example, or public housing, you are only allowed to earn a certain amount of money. In fact, you can only have $2,000 in the bank, maximum. And so the penalty is if you earn more than that or have more in the bank than that, you will immediately lose those subsidies. You lose the child care vouchers that enable you to work and earn this limited amount of money, food vouchers and housing vouchers. You lose it all at once. Now, I'm not suggesting that you should be able to make endless amounts of salary and money and live in public housing or have those subsidies. I'm saying people should be allowed to have a runway to exit those things, to get established financially where they don't need those things. But the way that it is set now, people are they don't want a better job. And they literally turn down promotions and things in our hospital for that reason. And so once again, we're driving this thing. The governor was like, she was almost stunned by the whole thing. And it's both federal and state in terms of policy. And she said immediately, she goes, okay, let's see, what's possible for us to do now at the state level. She really wants to, to address this. So, that's an example of that. And I'm a little bit anxious about it. I was waking up in the middle of the night last night thinking about this. I really was, because it means a lot. And I feel like we can get this done. And that won't be the only thing we'll work on. We'll work on, immediate and middle timelines for other approaches to that, like the work we have going on in the hospital as well, including financial literacy, financial intelligence, teaching people about money management and investment and those type of things. I think it should also happen in children at that level. So yeah.
Do you have a lot of interdigitation with companies, be it pharma or diagnostics?
Oh, yeah, right.
And how do they get involved with you and your organization?
So like right now we're working, and this was Trina's work again, working with life sciences, because now, you know, they want to know how, so they have pathways into their organizations now without people needing 4-year degrees. They have these programs that people can enter their spaces now and have salaries of upwards of like, I don't know, $80,000 or something like that without those degrees. They can get degrees if they want along the way, but we're working with people like MassBio, Takeda, Mass Sciences, all those names kind of, you know, they get mixed up, but in fact, they had Trina do a keynote for one of their convenings just last week. And so we're working with them to help them learn how to approach communities to actually create that pipeline into their space. Actually, one of them is already working with us. Takeda has already started that. So, so yeah, we work with lots of...
It just seems there are real opportunities for both diagnostics and pharma to interdigitate with the more appropriate utilization of populations that have heretofore not had access to some of these technology and
That's
techniques.
exactly right. That's exactly right.
There was several questions about the equity fellowship that you have and how to interdigitate with that. So they email you or they email Boston University?
They can email me. They can email me. That's fine. Absolutely. We're now on our, I think we have 5 now, 5 equity fellows. And they are incredible. They are helping the work perpetuate it, you know, helping to perpetuate the work. We also now have a whole curriculum, you know, on equity that we have, that includes almost everything I talked about here today, including the community work, the economic mobility work, the historical, you know, work about inequities. It's pretty extensive.
Well, what strikes me as unique is that it's not a matter of finding the gaps, it's a matter of filling the gaps.
Yeah, or eliminating the gaps.
Or eliminating the gaps.
Right.
And that's where some of this information might be uniquely beneficial, because I think lots of programs are still at the point of simply finding the gaps.
Right.
And then saying, now, what do we do about them? Your early stages. So is there a way to jumpstart one's ability to do this in a much more facile way?
Yeah, I think one of the things that'll get you started is to look for it, be willing to look for it, and when you find it, I think it's probably, it might be hard to just leave it when you see it, but and then have a commitment and an intentionality to do it, and bring in the people you need to help you do that. You have to bring in the right people to help you do that.
And that's the community.
That's the community.
Last question from the microphone. We have about 45 seconds left.
Okay, awesome. Thank you so much. Amazing talk. I was wondering, really striking to see that there's, 50 times higher gun violence incidents in your population. Devastating to see, actually. How are you handling that?
So we are part of the Health Alliance for Violence Intervention. And there are 5 level 1 trauma centers in Boston, but more than 70% of those cases come to us. And so we were founding members of the Health Alliance for Violence Intervention. There were 7 hospitals who started this work, and our program started out with just 2 guys who would visit the patients, every day, but now we have a full-on program where we have workforce development inside the program. Like one of the leaders in the program, he is a specialist in that space, connecting them to jobs. We have hired several people like that into the hospital from those programs. And those kids are hungry. Those kids get in one space and they're like, I'm going for that job next, I'm going for that job, kind of thing. We do that with them. We help them with education. They go get degrees. We help them to become, some of them are interested in the trades. help them become entrepreneurs, whatever it is that they want to do. We even like do things like take younger ones who've come in as victims of violence and sort of do mentoring with them, like exposure. Like they took a group of them to Cape Cod 2 or 3 weeks ago, and had them fishing down on the vineyard and stuff like that. So various different things like that. Oh, and it is aligned. We work in tandem with a mental health team who we work together. So it's not just us working with the victim of violence, but it's also behavioral health, and also with the family. We also help the family, to get stable. If they're interested in mental health or they're interested in housing, we help them with housing, employment, like everything. That's another thing that we haven't measured, impact-wise, because there are other hospitals, in the city who we also work with, in this space. But that's how we address that particular problem. And to me, it made it so much easier for me as an ER doctor when we started that program in 2006. Because when people came in now, it was no longer doom and gloom for me, because I saw them coming in as another opportunity for another person versus treating street, as people, sometimes call that.
Because that victim of violence is perhaps the next person who becomes the perpetrator of that violence.
That's exactly right.
So it's one person at a time.
That's right. That's right.
We need to stop. Unfortunately, we're out of time. Dr. James, thank you so much.
Thank you, Dr. Jaffe. Thank you, everyone.